Presenting today on neutropenic fever with an emphasis on duration. My title is Neutropenic Fever, How Long is Too Long? My content expert was Brian Buss. So thank you, Brian, for all the help with this presentation. So my objectives for this presentation is first, to describe the current guideline recommendations and literature for neutropenic fever treatment and prophylaxis. Second is to identify potential pros and cons to antibiotic de-escalation in neutropenic patients. And third, to apply information learned from this presentation to patient cases. So to start off, the definition of neutropenic fever is neutropenia and fever. And of note, there are slightly different definitions of neutropenic fever by different societies. So I got this one from the American Society of Clinical Oncology, or ASCO. So neutropenia is generally defined as an ANC less than 500 or expected to decrease less than 500 within 48 hours. And a fever generally is described as a temperature greater than 100 degrees Fahrenheit. This pie chart shows the proportion of documented infections versus unexplained fever in neutropenic fever. As you can see, over half of the cases, there is no explanation of fever or any infectious cause of fever identified. So often that means we are treating with broad spectrum empiric antibiotics for a prolonged duration, since we don't necessarily know what we are treating. Of the documented infections, most of them are due from bacterial infections. So I'll start off with the patient case. So we have X, who is a 60-year-old female with a past medical history significant for cardiovascular disease, COPD, and AML. She underwent an allogeneic hematopoietic stem cell transplant and is currently afebrile, but her ANC just dropped below 500 cells. So which antibiotic would you want to start in this patient? And you can put your answer in the chat. And I'm seeing some A's come through, which is awesome. And that is correct. So A, levofloxacin. Fluroquinolones are our go-to agent for this, currently recommended by the IDSA guidelines. And I want to point out here that there may be other prophylaxis agents you may want to start as well for PJP or HSV or etc. Does anyone know why we do this and we use fluoroquinolones prophylactically? If anyone would want to put in the chat if this is to prevent pneumonia, cellulitis, mucositis, or bacteremia. Any guesses? So generally, it is to prevent gram-negative bacteremia. And if some of you would have put C as an answer for this question, maybe you have already seen my slide deck, and I hope to convince you that that could be the right answer. So here's an overview of how I'm going to break it down for neutropenic fever by prophylaxis, empiric treatment, and de-escalation, and by the different guideline recommendations. The relevant US guidelines are ASCO or IDSA and NCCN. The relevant European guidelines are ECIL and ESMO. So overall, as you can see here, there is discordance in the national guidelines on recommendations for prophylaxis and de-escalation. We'll start with prophylaxis. And I just want to preface this that I am focusing on fluoroquinolone prophylaxis here for bacteremia prevention, but know that there's also prophylaxis for other infections such as HSV, PJP, and fungal infections that I won't be covering today. So the overall purpose of prophylaxis is to prevent infection and/or mortality related to infection. However, the data is questionable and debated. On the other side of the risk-benefit pendulum, there is a strong evidence for resistance in fluoroquinolone prophylaxis use, and there is always a risk for adverse events, especially when we are using fluoroquinolones. So we have to decide whether this increased risk for resistance and side effects is worth the decreased infection potential. Additionally, when going through the data on prophylaxis, it is important to consider which patient population is in the study because each setting and disease state have different levels of risk. It's also important to note here that even though the inpatient setting may have more risk for MDROs, there is a lot more monitoring and quick, easy access to IV antibiotic use if a patient does end up fevering, rather than in the outpatient setting. Additionally, allogeneic stem cell transplant patients may have more prolonged and more significant neutropenia than solid tumors, for example. So I want to start off with an RCT looking at fluoroquinolone prophylaxis. So I picked a very well done RCT in my opinion, but know that there are many out there like this. This RCT was in patients receiving cyclic chemotherapy for solid tumors or lymphoma who were at risk for temporary severe neutropenia. And I want to point out here that this population is generally considered low to intermediate risk. They compared prophylaxis with a fluoroquinolone to no prophylaxis in neutropenic patients. Their primary outcome was the incidence of clinically documented febrile episodes attributed to infection. And they had a total of around 1,500 patients. Fever occurred in around 11% in the levofloxacin group compared to 15% in the placebo group, which was statistically significant. For hospitalizations for infection, this occurred in around 16% in the levofloxacin group compared to 22% in the placebo group, which was also statistically significant. However, there was no difference in severe infection and/or death from infection. So overall, levofloxacin decreased overall fever and hospitalization, but not severe infection or death in those patients who were at risk for temporary severe neutropenia. So my question here is, are we comfortable with the increased fever and hospitalization in this group if mortality is unaffected and spares those who don't fever from unnecessary use of fluoroquinolones? The answer historically would be yes, because of the ease to start empiric treatment if needed. And for most guidelines, that is not an indication to prophylax. Usually it's only severe infection and mortality. So let's dive into the literature more. I dug through all of the meta-analyses that exist for this topic and highlighted the most influential ones here. So the first meta-analysis in 2005 looked at only RCTs and all malignancy groups, and they found no mortality difference. The second one by Chimera also looked at only RCTs with a little bit more patient population, but only looked at the stem cell transplant population, but also found no difference. The third meta-analysis in this table was by a study by Gafter and Golvey. This meta-analysis changed practice when it originally came out in around 2007 and is what drove certain guidelines, specifically the ASCO guideline, to change to suggest fluoroquinolone prophylaxis. They looked at all malignancy groups and happened to mostly include stem cell transplant and heme malignancy patients, and found that they had a statistically significant mortality benefit in fluoroquinolone prophylaxis. And the last meta-analysis that I reviewed is a newer one, but included more observational studies. This one also looked at mostly stem cell transplant and heme malignancy patients, and they did not find a mortality difference. So just to summarize, overall, only one meta-analysis was statistically significant for fluoroquinolone mortality benefit, and that was the Gafter-Golvey meta-analysis. So you're probably giving me this face and are maybe confused to how to conclude this data. So let's see what the guidelines concluded. So the IDSA guidelines cite the Gafter-Golvey meta-analysis as evidence to support fluoroquinolone prophylaxis. They recommend fluoroquinolone prophylaxis in patients who are at high risk for neutropenic fever, and typically are patients with AML, MDS, treated with myeloablative conditioning regimens. The European guidelines do not recommend prophylaxis in any patient population. This recommendation is based on inconclusive data and the concern for resistance. And interestingly, the Australian guidelines also don't recommend prophylaxis either, except it can be considered in outpatient stem cell transplant patients and palliative care patients with no bone marrow recovery, so extremely high-risk patients. So since our guideline changed recommendations based on this meta-analysis by Gafter-Golvey, and is the difference here between the guidelines, I dug into that one a little bit more. So their primary outcome was all-cause mortality at 30 days of follow-up or at the end of each study. And it was statistically significant for overall prophylaxis with a number needed to treat of 34. They had other outcomes, but if overall people are dying more without fluoroquinolone prophylaxis, then resistance and side effects aren't as relevant. So let's dig into mortality a little more. This is their primary outcome, looking at overall prophylaxis, which included all antibiotics, versus none for all-cause mortality. And I want to highlight that all of these studies are generally older. The studies range from 1980 to 2009, but majority are all before 2000, which was when fluoroquinolone prophylaxis wasn't recommended by the guidelines. So theoretically, less fluoroquinolone use back then equals less resistance than we have now. Secondly, the majority of the studies in this meta-analysis looked at heme malignancy patients and mostly stem cell transplant recipients who tend to be the most neutropenic for the longest durations. So looking at these studies and how they were weighted, only 2 out of the 18 were statistically significant on their own, and they were weighted pretty heavily and are likely driving the outcome towards favoring prophylaxis. So I highlighted those and then dug into those a little bit more specifically, and then I also looked at 2 others that were trending towards significance and heavily weighted as well, to see if there was a certain patient population they are focusing on or if there were major flaws. So here are the study details. First, the Sleefer study in 1980. This was an overall gut decontamination study, which is not done anymore because of tolerance and lack of absorption of the drugs. Generally, patients get severe diarrhea. They use naldixic acid, polymyxin, and Ampho-B for the entire duration of neutropenia, and patients, as you can imagine, did not tolerate that. But their primary outcome looked at overall mortality, which occurred in 9 out of the 53 patients in the controlled group versus none in the antibiotic group. However, we do not know if they died from an infection or something else. So overall, it's hard to make any conclusions since we don't know the cause of death, and gut decontamination is very different than fluoroquinolone prophylaxis in general. The second study by Fan in 2001 looked at ciprofloxacin plus a macrolide versus placebo in small cell lung cancer patients, who generally are low-risk patients. This was not statistically significant, but was trending towards that direction. And we can only apply this information to the low-risk patient population, which we wouldn't prophylax with anyways. And the third study that is listed here was the second one that was statistically significant. They used many fluoroquinolone options versus placebo, and they had 4 deaths in the placebo group compared to none in the antibiotic group. Overall, could be useful in these patients, but is a very small sample size of a single center study of only 30-ish people in each group. And the last study by Vancomycin in 2005 was a pretty well done study in my opinion, but can only be applied to stem cell transplant patients, since that was the majority of their patient population. They compared levofloxacin to placebo and didn't have a statistically significant outcome. And interestingly, they also looked at resistance, and out of the 47 infections in the levofloxacin group, almost all of them were resistant to fluoroquinolones versus half were resistant in the placebo group. So to summarize these, there's really only one statistically significant study that is comparable to modern prophylaxis, and it was a very small study. Now, looking at fluoroquinolones specifically for prophylaxis versus none, there was only one study that was statistically significant, which was, again, the gut decontamination study, which is highlighted here on the top. And then the second one was the Vancomycin, which was trending towards significance, but again, was mostly in the stem cell transplant patient population and wasn't significant. So in conclusion here, fluoroquinolone prophylaxis specifically, there are 2 studies that drive this meta-analysis towards significance, and only one evaluated modern prophylaxis, which wasn't statistically significant. So if using fluoroquinolones didn't have any consequences, that would be amazing. But as you know, that is not the case. The biggest concern listed by other guidelines is resistance. There's a ton of data to support the longer you use a fluoroquinolone, the more resistance. However, most of the RCTs in these studies only have a 30-day follow-up, which is not long enough to assess resistance. Therefore, it may seem like resistance isn't statistically significant, but it definitely could be if there was a different time frame to the study. I listed a few studies that showed resistance in fluoroquinolone prophylaxis use here. The first one being the study by Baum in 2000, which looked at the prevalence of ciprofloxacin-resistant E. coli in hem-onc patients on fluoroquinolone prophylaxis. And of the 30 patients colonized with E. coli, 82% were resistant to ciprofloxacin. The second study by Kern in 2005 also looked at E. coli And after patients were started on fluoroquinolone prophylaxis, their resistance increased from 15% to over 50%. And the last one by Hockey in 2019 shows how fluoroquinolone prophylaxis can drive meropenem resistance. In this study specifically, fluoroquinolone prophylaxis increased the odds of meropenem resistance by 14-fold. And I'll go into the reasoning behind that a little bit more. So there are three main mechanisms of Pseudomonas resistance. The first being AMP-C beta-lactamase production that breaks down beta-lactams. The second being loss of porins that don't allow drug into the cell. And third, efflux pumps that pump drugs out of the cell. Efflux pumps specifically are important for fluoroquinolones and carbapenems because they are substrates of the MEX-AB OPERA-M efflux pump that can be upregulated in Pseudomonas. So fluoroquinolone exposure can upregulate these efflux pumps and can eventually cause resistance to fluoroquinolones and carbapenems at the same time. So we lose our key player for pseudomonal and ESBL infections when we use fluoroquinolones. And I can show you how clinically significant this can be. So this graph by Hockey, or this table by the Hockey study, looked at Pseudomonas bacteremia isolates. And of the 26 patients on fluoroquinolone prophylaxis, none were susceptible to ciprofloxacin, and only 15% were susceptible to meropenem. Compared to the patients not on fluoroquinolones, they had 29 patients, and about 72% were susceptible to both ciprofloxacin and meropenem. And not only is resistance a huge concern, but C. diff can be a major issue as well in this patient population. So a Korean study found that patients with heme malignancies were much more likely to have C. diff than non-heme patients. And this was attributed to the higher use of causative antibiotics, particularly fluoroquinolones. So I just went through a ton of data. So I want to summarize everything I just went through for prophylaxis. Overall, there is one main meta-analysis that has been statistically significant benefit on mortality for prophylaxis. Of the 19 RCTs in that meta-analysis, only 2 were statistically significant. One being a gut decontamination study, which is not tolerated or done anymore, and the second being a smaller single center study. So from that, Europeans conclude that overall there is low benefit for a clear correlation with resistance and increased risk of C. diff, which is why they do not recommend prophylaxis. Americans, on the other side, recommend prophylaxis based on the mortality benefit seen in the Gafter-Gulvey study, despite the poor quality of data. So back to our patient case. And just to recall your memory, our patient has AML and underwent an allogeneic stem cell transplant, who is neutropenic on fluoroquinolone prophylaxis, and she is now spiked a fever. What else would you like to know before recommending an antibiotic to start or escalate to? And you can put your answer in the chat. All right. Well, you may want to know if this patient is clinically stable or if they have any drug allergies, they have history of drug-resistant pathogens that may guide you towards a certain antibiotic versus another. So here's some additional information. So our patient is still neutropenic, is hypotensive, has no allergies, and has no history of MDROs. So with that information, what antibiotics would you want to start? And you can put your answer in the chat. Awesome. I'm seeing some A's come in. So cefepime and vanco are our go-to agents for neutropenic fever unless the patient has some history of MDROs or a certain infection is suspected. So moving on to empiric treatment. And I want to preface this with that I am focusing on the inpatient setting here. You can treat certain patients with neutropenic fever outpatient, and you can find more about that in our UW guideline. And I'm not also going into extensive detail about empiric treatment since this presentation focuses on duration. But generally, all of the guidelines recommend an anti-pseudomonal beta-lactam plus or minus vancomycin. But as always, we tailor our antibiotic choice to the patient's history and depending on what infection source is suspected. And this is pretty similar for both Europeans and American guidelines. So when is it recommended to use vancomycin? I think this question can be simplified to ask, well, where is staph on our body? And what infections do we normally cover for MRSA? So that would typically be skin and soft tissue infections, hospital-acquired pneumonia, hemodynamically unstable or septic patients, and catheter or line-related infections. And that is what our guideline recommends. So we can relatively discontinue the vancomycin quickly if none of the following are suspected. So severe mucositis, skin and soft tissue infection, indwelling catheter infection, resistant strep pneumoniae, hemodynamically unstable or MRSA pneumonia. And it is great that we can de-escalate relatively quick off the vancomycin, but for the cefepime, how long do we continue that for is a question you may be wondering. So de-escalation of cefepime or any anti-pseudomonal beta-lactam is different based on the guidelines. The US guidelines de-escalate to a fluoroquinolone, which is debatably not really a de-escalation, which is why I didn't put anything in this box here. And European guidelines do recommend de-escalation in certain patients. So back to our patient case, X is our patient with neutropenic fever, escalated to vancomycin, and then she ended up de-escalating back to levofloxacin once she was stable and no signs and symptoms of infection. But she is still neutropenic. And now she has been on antibiotics for over 14 days, which is longer than most treatment courses of infection. So which guideline recommendation therapy does this follow? And I'm seeing A's come in. So yep, that is what we do here. That is the US guidelines. So moving on to de-escalation. The ASCO and IDSA guideline recommends to continue empiric treatment until resolution of neutropenia. And if an infectious source is identified, at least the treatment course for that infection. And this is recommended based on expert opinion. The European guidelines recommend to de-escalate to no antibiotic, regardless of neutrophil count, after the patient has been afebrile, stable, and no signs and symptoms of infection for 72 hours. The ASCO's supporting evidence for this duration is based on a study by Pizzo from 1979. This was the only randomized reference study to support their approach, listed by the guidelines, and there were only 33 patients total in the study. Half of them were randomized to continue antibiotics until ANC recovery, and the other were randomized to discontinue antibiotics once stable. The majority of patients were leukemia patients, and only 1 out of the 16 developed infection in the antibiotic group, which the antibiotics they used here were gentamicin and carbacillin. And 7 out of the 17 patients in the no antibiotic group developed infections, and 2 of those ended up dying from E. coli bacteremia. So overall, this study does have its flaws. It's very old and has a very small sample size and has different empiric antibiotics that we use today. So what has happened since 1979? There are a number of studies to support de-escalation, and these are just a few to support stopping antibiotics rather than continued use. I won't go into depth about these studies, but generally they all looked at mortality, hospital readmission rates, and infection rates. They all generally found no difference, and originally, interestingly, most of these RCTs were in pediatrics. So the How Long study has been a big study that looked at de-escalation in Spain, and it was published in 2017. They included heme malignancy patients or patients undergoing a stem cell transplant with high risk for neutropenic fever and no microbiological diagnosis of infection. The experimental group continued empiric antibiotics until the patient was afebrile, normal vital signs, and no signs and symptoms of infection for 72 hours, regardless of neutrophil count. The control group continued empiric antibiotics until all of the same criteria, but also had neutrophils above 500. The main primary outcome was mortality and antibiotic-free days. Mortality was actually lower in the experimental group, but was overall not statistically different between the two groups. Antibiotic-free days was statistically significantly lower in the experimental group by an average of 3 days. And there were more statistically significant serious adverse events in the control group, the highest being renal failure. And I just want to highlight here the criteria for de-escalation that was used in the trial. If all of the following were met for 72 hours, then they de-escalated antibiotics to no antibiotics. And that is no indication of infection, afebrile, resolutions of signs and symptoms of infection, and normal vital signs. And this top table points out the different sources of fever in these patients, which aligns with previous data, with the majority being unknown. There was also no difference in infection rates between the two groups. And then the bottom table points out that the study population was mostly heme and not allogeneic stem cell transplant patients. So I covered a lot for this trial. So I want to conclude this trial specifically. In high-risk patients with neutropenia, the clinical approach is better than the standard approach of waiting for neutrophil recovery to initiate withdrawal of antimicrobial therapies in otherwise afebrile and stable patients. And the fear of recurrent fever and secondary infections and increased mortality is not justified by extending durations of antibiotics until count recovery. And overall, I just want to summarize de-escalation as a whole. The IDSA or ASCO guidelines reference one study from 1979 to support the prolonged and continued use of empiric antibiotic treatment. And the How Long trial shows a clinical approach can be safe and can spare days of broad spectrum antibiotic therapy. Now, to summarize everything that I covered so far, and this is, in my opinion, prophylaxis has not been shown to consistently reduce mortality rates despite adequate evidence that it supports efficacy in reducing febrile episodes. Second, guidelines on neutropenic fever prophylaxis and de-escalation around the world are conflicting based on inconsistent meta-analyses and fear of resistance. Third, emerging drug-resistant pathogens in the stem cell transplant patient population is a concern with the routine use of fluoroquinolones. And then lastly, the How Long trial showed benefit in antibiotic de-escalation in neutropenic patients, which mainly included the non-stem cell patient population.